Hello, everyone. Welcome back to my YouTube channel. My name is Dr. Hamid, and our today's topic of discussion is immunodeficiency syndrome. Very important topic, very high yield topic for step one and step two preparation. I have seen a lot of questions from immunodeficiency or B cells and T cell disorders. Um, I would recommend before we jump into our topic, I would recommend using first aid side by side with your UWorld. Don't do passive reading of first aid. Do as many questions as you can from UWorld and annotate high yield points from UWorld to first aid. Um, Before we jump into our topic, I really want to discuss immune system organs first because our today's topic is B cell disorders, and you should know where our body is producing B cells, what part of our body is producing B cells, and how the body is producing, and how where they are getting matured, and what is their function. So first of all, our body has two types of lymphoid organs, primary lymphoid organs and the secondary lymphoid organs. Primary lymphoid organs are bone marrow and thymus. Bone marrow is the site, you always remember, bone marrow is the site where immune cells are produced, like B cells, T cells, natural killer cells. These all immune cells are produced in the bone marrow. Okay. um, but B cells also get matured in bone marrow. So bone marrow is not only producing all immune cells, but it is also the site where B cells are getting matured, while T cells get matured in thymus. Um, this is very high yield point you should remember for your step one specifically. Bone marrow is the site of B cell maturation, and thymus is the site of T cell maturation. But T cells are produced in bone marrow. Both B cells and T cells are produced in bone marrow, but B cells get matured in bone marrow and T cells get matured in thymus. Secondary lymphoid organs are spleen, lymph nodes, tonsils, pear patches in our gut lining. These are the secondary lymphoid organs. And why we call them secondary lymphoid organs? Because they allow immune cells, secondary lymphoid organs allow immune cells, our B cells, T cells, to interact with antigen. And why we are saying that bone marrow and thymus are the primary lymphoid organs, because these are the sites where bone marrow, I mean immune cells, are produced and getting matured. Okay, so let's jump into B cell disorders. And here one important point: if you will see the image of lymph node specifically, this is the image of lymph node. um, so this is the lymph node, and this outer portion is the cortex, the middle portion is paracortex, and the central portion is medulla. So in lymph nodes, B cells are present in cortex, while T cells are present in paracortex. Okay, so B cells are present in cortex, and these yellow things. These are follicles. Okay, and these follicles contain primary I mean, they contain B cells. So outer portion of the lymph node, that is called cortex, contains follicles, and the follicles has B cells. Okay, so let's jump into our first topic, which is X-linked or Bruton Agammaglobulinemia. From the word B, they have highlighted here. You should remember this letter B, so that would make this topic very easy for you. So there is a defect in X-linked agammaglobulinemia. There is a defect in BTK gene, a tyrosine kinase gene. So when this gene is defected, B cells will not mature. And we already know that, I have already emphasized that B cells are get matured in bone marrow. So you have a basic concept that B cells get matured in bone marrow. So in X-linked agammaglobulinemia, there is a defect in BTK tyrosine kinase gene. So B cells will not mature. And what is going to happen if B cells are not getting matured? B cells are the part of immune system. B cells provide us humoral immunity. Humoral immunity is the is a type of immunity in which our body produces antibodies. B cell provides humoral immunity. What happens is when B cells get mature, it differentiates. B cells get differentiates into plasma cells, and those plasma cells then produce antibodies, and then antibodies fight against antigens, foreign antigens. So what happens in Bruton gamma globinemia? B cells will not get mature. There is a defect in B cell maturation. When these B cells are not getting matured, they will not differentiate into plasma cells, and they cannot produce, eventually they cannot produce antibodies. And when antibodies are not present, they cannot fight against infections. So what happens? There would be recurrent bacterial and enteroviral infections in babies, and specifically this disease is common in boys, not in girls. It is X-linked recessive disease. I have already discussed lionization, a topic you guys should go there if you haven't watched that video. It's very important. That will give you the concept of why X-linked diseases are seen in boys and not in girls. So, X-linked agammaglobulinemia, Bruton agammaglobulinemia, there is a defect in BTK gene, no B cell maturation, no antibody production, antibodies are not present. So, there is an increased risk of recurrent bacterial and enteroviral infections after 6 months. Not before 6 months, very uncommon before 6 months, because babies in their first 6 months they have maternal immunoglobulin G. They have mother's immunoglobulins. They have in their blood, they contain antibodies, IgG antibodies from mother from their mom, that protects them against infection. And the level of that maternal immunoglobulin or maternal antibodies, they level slightly, by the time that level gets decreased, and then due to that um, when the level of immunoglobulins get decreased, the chances of recurrent bacteria and enteroviral infections get increased, because these babies don't have antibodies to fight against infection. So what and now what type of infections we'll see in Bruton agammaglobulinemia? There usually babies in their 6 months, they will present with recurrent otitis media. Otitis media is an infection of the middle ear. Sinusitis, infections of sinuses. Pneumonia, they can present with giardiasis. Recurrent infections due to echovirus, polio, or coccidiovirus. So these are the present. These could be the presentations of babies. In the hospital setting, what would be the findings? We see absent B cells in peripheral blood. Obviously, what we'll see in the lab work, there will be absent B cells. All immunoglobulin classes will be decreased. No IgG, no IgA, no IgM, uh, no immunoglobulins at all. Absent or scanty lymph nodes and tonsils. I've already discussed that lymph node has three parts: cortex, paracortex, and medulla. Cortex is the site that contains B cells, and specifically, cortex has follicles, and those follicles contain B cells. So when B cells in this disorder, when B cells are not produced, the follicles will be absent or scanty, because follicles contain B cells, and in this disorder we don't have B cells. Okay. And live vaccines, one important thing you guys should remember, is live vaccines is contraindicated. Why? Because already our body, babies don't have immunoglobulins, they don't have antibodies to fight against infection, they are immunocompromised. So if we give them live vaccines, we are giving them um, active antigen, so they cannot fight against the infection. So that would further increase the risk of infections, or that could deteriorate their medical condition. So that is the reason live vaccines are contraindicated in X-linked agammaglobulinemia. Now, let's jump into our second topic, which is selective IgA deficiency. Or from the name, it is very clear that there is going to be deficiency of immunoglobulin A, and then other immunoglobulins will be somewhat normal. So, selective IgA deficiency, the cause is unknown. The exact cause, we don't know the exact cause of selective IgA deficiency, but it is in this selective IgA deficiency, you should remember that there is a defect in B cell differentiation. So, in X-linked agammaglobulinemia, there was a defect in B cell maturation. B cells are not maturing, and then if they are not maturing, they would not differentiate. In selective IgE deficiency, B cells get mature, but they don't differentiate. When they don't differentiate, they cannot produce, again, they cannot produce antibodies. So make these things very clear that selective IgE deficiency, there is a defect in B cell differentiation, where specifically IgA is not produced properly. From the name, it's very common. It's understandable. It is the most common primary immunodeficiency syndrome. Out of all B cells and T cells disorders, selective IgA deficiency is the most common type. Okay, what happens in selective IgA deficiency? Low or absent IgA, but normal IgG and IgM. Okay, IgG and IgM levels will be normal, only IgA will be deficient. And you know that IgA, you should know that IgA is the main antibody. It is the main antibody found in mucosal secretions like gut lining, respiratory tract lining. So, IgA is usually present in the mucosal secretions in the airway and GIT. So, that is the reason the patients are more likely to have recurrent respiratory and gastrointestinal tract infections. Okay. Um, what are the common associations you should remember? So they have made things a lot clear, like from the word IgA, you should remember majority of the patients are asymptomatic, and I've already discussed that IgA is present in mucosal secretions of the airway and GI tract. So we'll see airway and GI infections. Okay, you should remember that what are the common associations of selective IgA deficiency? Autoimmune diseases, from A, autoimmune diseases like celiac disease is commonly associated with selective IgA deficiency. Um, uh, SLE, SLE is systemic lupus erythematosus and rheumatoid arthritis. These are the three autoimmune diseases you should remember that have association with selective IgA deficiency. From A, you should also remember atopy, like allergies and asthma are very common in patients with selective IgA deficiency. Anaphylaxis can happen in patients if they receive blood products. That contain IgA. If one patient has selective IgA deficiency, and if we transfuse any blood product that contains IgA, um, um, there is increased chances of anaphylaxis. Why? Because the body see IgA as foreign, because body does not have IgA, and when we transfuse the blood product that contains IgA, it body will react against that IgA, because body will think that this IgA is foreign. So important things you should also remember, that they are these patients with selective IgA deficiency, they can have I'm repeating that increased risk of airway and GI infections. In GI infections, you should remember that they are susceptible to GRDSs, because they don't have IgA to protect mucosal lining. And yeah, and What important thing you guys should remember is lab findings. If we'll do the lab work, what we will see, we'll see low IgA and normal IgG and IgM. Yes. Also, one important point related to selective IgA deficiency you should know from exam point of view is that in celiac disease, um, if we'll do the celiac disease test, you might get a false negative in these patients, in patients with IgA deficiency, because false negative test in celiac disease is false negative celiac disease test. So what I'm trying to say is, usually for if we usually we check celiac disease by IgA based tissue transglutaminase test, and IgA deficient patients don't have IgA. So if we'll check celiac IgA based tissue transglutaminase test in these patients, we will get false negative result. So because patient does not have IgA, we cannot this test, IgA based test for celiac disease, um, is not a reliable test for these patients. So we should order IgG based test instead of IgA based celiac test. So false negative celiac disease test is very common in selective IgA deficient patients. Okay, now the last topic is common variable immunodeficiency. Bruton Agammaglobulinemia and selective IgA deficiency, very common in early age groups, like usually you see around the age of 6 months, and I mean they get start very early around the age of 6 months. But common variable immunodeficiency, usually you'll see it in adolescents or adult patients. So common variable immunodeficiency, again, defect in B cell differentiation like selective IgA deficiency, cause is unknown like selective IgA deficiency. Okay, B cells are present in common variable immunodeficiency. Um, but again, they get mature, but they do not differentiate to produce plasma cells, and then those plasma cells cannot produce, if they are not maturing to plasma cells cannot produce antibodies. Usually diagnosed after puberty, like young adults or adolescents and young adults, and there will be decrease because again, if B cells is not differentiating, so it will there will be decreased level of plasma cells. B cell will be present, normal B cell count. When we'll do the lab test, we will see in common variable immunodeficiency, normal level of B cell, decreased level of all decreased level of plasma cells, and decrease all immunoglobulins, IgG, IgM, IgA, IgD, all immunoglobulins will be decreased. Somewhat common variable immunodeficiency is somewhat similar to Bruton Agammaglobulinemia, but you should remember the age difference. Usually in the exam, age is very important, gender is very important for so you should see these important these small points are very important. So in common variable immunodeficiency, always if you are thinking about common variable immunodeficiency, just check just double check patient's age group. Okay, usually in Bruton they will give you Bruton Agammaglobulinemia around the age of 6 months to 1 year. Common variable immunodeficiency, usually they give you adolescent and adult patients. Okay, what will be the features of common variable immunodeficiency? Again, recurrent sinopulmonary infections and increased risk of autoimmune diseases. There is increased risk of bronchiectasis because of recurrent sinopulmonary infections, increased risk of lymphoma and other malignancies can also occur, increased risk of rheumatoid arthritis as well. Okay, so I think this is all about B cell disorders. If you guys have any questions, you can ask me in the comment section and let me know if any specific topic you want me to discuss. Thank you.